We are very pleased because we just had two amazing sessions about sexual function at the ICS. So one round table and one workshop about sexual function. We had the opportunity and the chance to add Heather Award with us and Dee Hartman that were presenting their expertise about sexual function. So I would like to start by asking you, what was the most surprising in the two sessions?
Well, we didn't have enough time. We could have used a lot more time because we all like to talk too much, and we all are. So, Heather and I think in particular, are so excited to be here because we get to talk about things that we never get to talk about anywhere else. So, right? Well, you might get to talk about it more than.
I talk about sex all day, every day, but I don't get to speak to this audience normally,
Yes.
and it's nice to speak to an audience who's really hungry for the kind of information
Right.
that we teach.
And can you tell the audience what you had to present today?
I knew you were going to ask me that, and keeping it straight was really quite difficult. But the biggest piece is the journey that women take from chronic vulvar pain and sexual dysfunction into finding their pleasure and getting rid of the pain and then enjoying all of the personal intimacy that they can. And that's really what it's all about. It's all about education and helping get that pathway to more and more people.
And I think it's so important because as health professional, physiotherapists, what we tend to do is to be very biomechanic.
Right.
And listen to you talking about pleasure, and this broaden our perspective about treating women with pain, because it's not, the focus should not be on pain anymore.
Right.
And I think that's a very innovative approach
Right.
that we should incorporate it into our practice.
Right. And then that's really what drove me to where I am now, because I had this old colleague, and she was this pleasure person and I'm the pain person. And what I oftentimes say is that women's health physical therapists and counselors, CBT, and surgery, when it comes to chronic vulvar pain, are really pretty successful at getting rid of the pain. And we say, okay, your pain's gone, now go do it.
And it's not happening.
In hindsight, it's just not happening, because our patients who have recovered from pain, even though they don't have pain anymore, never reach the same sexual function as their non-pain peers. So we're missing something. I talked about sex for forever, but I just didn't talk about it enough. So now I'm kind of pushing people to talk about it a lot and adding a lot more fun stuff.
And what I like about your presentation is that you're providing some cues, some tips that we can use. So can you tell us more about that?
Of course. So, we spoke twice. So first it was a round table. And in that I talked about how providers can open up the conversation with patients, because it's so important to patients to be able to talk about sexuality. So, wow, that lecture went so quickly. I feel like I just kind of cut it off part way because there's so much else to say. But I think it's important for providers to know ways that they can open up the conversation, and that they don't need to be experts. They can simply be a gateway to get people to provide referrals and help someone along their clinical path. And there is certainly, for those who want to know more, there's training available. And yet, I think just having people be interested in learning how to open up the dialogue is important. So we talked about that, and then in the workshop we talked about, and I'm trying to remember because my memory is not perfect here, but in that one I talked more about the relational aspects as well. So, and it's really following on what Dee was saying. Just because you relieve pain does not mean people are actually reintroducing sexuality or introducing it for the first time. And it's, sex between partners happens in a partnered experience. It's, that's the context. And so if people have gotten out of the habit of connecting, or if a partner's afraid of causing pain, or they're afraid, they feel better, but the person who's had pain is afraid that anything can trigger the pain again, they can be really tentative. So figuring out how to slowly get people back into the habit and find things that feel safe enough, to begin expanding that comfort zone is so important.
And in your second presentation, you discuss about some tips and position that the
Yes.
couple, and you presented the library of different video that you're using in your clinical practice.
Right.
And when you presented that, it struck me to say, it might be a very useful clinical tool, because you're kind of forcing people to communicate their needs and what they wish and what they like. And I was thinking that might be like a therapy in itself, to be able to watch those video about the position depending of the pain and their musculoskeletal condition. And I was really wondering, are you using it as a communication skill tool?
I am. I find any kind of educational materials that spark conversation are important, and really a lot of people don't know how to talk about sexuality, so when they have tools that are specific, they can begin talking more specifically. It normalizes the conversation for them. When they can observe people trying things out, and they can see the demonstration or the modeling of the experimental process, it can be really helpful. So that can be therapeutic just to watch something, but also it really sparks that conversation, and that's what a lot of couples need. They often haven't thought creatively in a long time. Often everything shuts down, so they just start narrowing their possibilities versus expanding. And that's why I love what Dee talks about too with pleasure, because it really allows people to expand their options and to think outside of the literal and figurative box of sex.
Right. And for me, my real purpose now, because I'm no longer in the clinic, I'm no longer seeing patients, is to really reach as many multidisciplinary providers as I can to hopefully help them begin to start the conversation, and start it with basics. Can I bring in my clitoris here?
Please show it. Even it's not yours.
This is my clitoris, yeah. Because I really think that if we can get all multidisciplinary practitioners to begin to think more of the entirety of the clitoris and the arousal network, but think of it from a functional perspective. First from an anatomical perspective, and then from a functional perspective, that maybe we could get it out of the gutters, we could get it off porn, we could say, look, this is a structure in your body, we know that this is what it looks like, and we know this is how it works. And help to educate women and their partners on how to reach the greatest height of pleasure, whatever that may be for any given person, but to give them the tools that they need to be able to do that. And that's what and that's really where my passion lies now, and really trying to educate women's health physical therapists as well as multidisciplinary practitioners who are dealing with women with all sorts of problems. I mean, I'm taking it from the vulvar pain perspective because that's where my history is. But this applies to everybody across the life cycle. It doesn't matter how old they are, it doesn't matter where they are and what they've done in their lives. It matters. And pleasure matters.
And concretely, when you are in your clinical practice and you were prescribing those pleasure activity, and this goes back also to both of you, that are you concretely prescribing some exercise or activity to do to facilitate those thinking about pleasure and introducing pleasurable activities?
Yeah. I wish I could say that I had done it more when I was in clinical practice. I've been out of clinical practice for 6 years now. I've been talking about sex with my patients since 1995, so it's not something that I didn't talk about. And interestingly, one of the hardest things, I've talked to my patients about self-pleasuring and make sure they get in the history. Sometimes they would tell me right away, sometimes they wouldn't. But the hardest thing I ever got women to do was to use their self-pleasuring practice during partnered intimacy. Yeah. They just wouldn't do it. They could have wonderful orgasm and very great sexual pleasure by themselves, but they were too worried that their partner would be offended.
Okay.
And I realized I want to go back and see everybody I ever saw before, but I don't think that's going to work.
And I think that the hardest thing is you worked with an individual usually, whereas in my case, I can work with, more often than not, I work with couples. Even if I'm focusing on one partner, because coupled sexual activity is about the relationship, I try to at least see if I can get if the other partner will attend, try to get the couple in to talk about what both of their needs are so that they both feel invested in the process.
Yeah.
And it's very difficult, if someone were facilitating that conversation about bringing self-pleasuring in, it gets much easier.
Right.
But expecting someone to take that home when they already feel, since they've had a pain condition, women. They already feel abnormal enough. They don't want to feel like they're introducing something else which is unusual, which in fact it's quite common for people to bring in self-pleasuring practices, but if they haven't seen that modeled, they don't know that.
Yeah, and interestingly, that's why I wrote my book, our book with my co-author, was really to help women explain to them anatomy and pain and how to get past that pain, but then how to go to sensual pleasure and then leading into sexual pleasure all by themselves. They don't have to have a partner, but it was our sense that until women really could figure out how their own bodies worked for themselves, it was pretty impossible for them to tell partners how to make them feel better. So it's a real passion that women figure out what's going on in their bodies and what makes them feel good, so they can then share it. If they so decide to do that, they may keep their self-practice all to themselves.
That's right. And a lot of people don't have the desire to do their own self-pleasuring, and so often they may have more responsive desire. So at least when they're working in a clinical setting with a sex counselor, we may be starting with, I know you talked about all forms of pleasure, all the 5 senses. And so we may be talking about ways for people to just become connected with their bodies again.
You better believe it.
And so being able to work with a partner, it might give someone more incentive or more investment to begin exploring pleasure for themselves. And then hopefully that will pick up. But really, we again have to look at the motivation and the goals of the partnership and what each person wants.
I totally agree. Well, and we know that those who are partnered, usually if they're in some sort of sex research, typically if they're partnered, they're more compliant with anything they're asked to do.
Yes. Yeah, that's one of my questions. What about the compliance of these advice, either that you're seeing the couple or seeing the individual? I mean, sometimes you may have been struck with some close, they don't feel that they wish to have penetrative intercourse and they are coming for that, and you're suggesting otherwise. So are you having some restriction or barrier?
Well, and interestingly, it's our sense that if we were able to get them to full sexual pleasure, then once they got that full arousal and they knew what it felt like to have a healthy orgasm. And again, the first two-thirds of the book is about that, and the last third is about taking it to a partner, whether they want to or not. That's certainly the encouragement, if that's what they want. I mean, so it's a real catch-22, and it just depends on who it is that's looking at it and who is that's picked it up and wants to do.
I think it's really about understanding each person's motivation and how each person learns too. If I have couples who aren't, compliant with their home play, I call it home play. If they're not compliant with their home play, then we want to look at why that is, what the barriers are, and that becomes the focus of our work a lot. It's not just there's no punishment for it. These are invitations. But if someone's not following up on those invitations, maybe that's really a symptom of low motivation, or feeling angry or frustrated in the relationship, or feeling exhausted. So I think it's really looking at what are the barriers, and we learn that through the process of experiments.
Yeah, right? So it's
part of the experimental process.
It becomes part of the therapy. The non-adherence is becoming part of the therapy, or the counseling.
Right, thank you. Sex counseling. So I'm a sex counselor, which means I actually do brief therapy, and I refer out for intensive therapy to someone who's a trained therapist. But I know you mentioned the how-to before. That's specifically what a sex counselor trains in, is the how-to, and it's very solution focused. You mentioned putting out your book and what your motivation was. For me, I put out a series of videos and a position library because, first of all, I found that I was having similar conversations with many clients around their health conditions, and I picked 3 of the most common, health conditions for physical mobility: pelvic pain, hip and knee problems, as well as spine problems, and put out videos that were accessible to people, because not everyone can afford to come and see someone or have access. And also, again, I wanted to make this available. So those videos are available. They're courses for individuals as well as for providers. And I also put together the library because I needed, you mentioned, is it part of the process? I needed tools to show my clients, and I wasn't going to be getting in sexual positions with my clients to show them positioning or how to get in and out of positions. And so I needed to demonstrate getting in and out of the positions and the positional modifications. But it's turned out to be, as you said, a resource where we go through any kind of tool where someone's having modeling, and is going to spark a conversation. And so it's been a great tool for me to have in clinic. Just once you open up the videos and people start looking at the different, clips, the still clips, they start, oh no, I don't think I would like that. Oh, I think I like that because, but that they start externalizing their thought process, and then communicating with themselves and each other.
And what I appreciate about that is that it gives some valid source, because people don't know where to look at and which information is valid out in this world of the web. I mean, there's a lot of false information, and I think that's very interesting. And it's more helpful than the handouts that we used to give them about positioning and some drawing. Yeah. It's really a next level.
Yes. Well, and it was intended for physical therapists because you do that kind of work. And I actually worked with a number of PTs to put together the options, right?
You sure did.
I sure did. Thank you to one of them right here.
Yes.
But I was very fortunate that I work with so many PTs, and of course I think physical therapy is life-saving. It was for me. I have a pelvic pain condition as well, so it was really helpful for me. But because of that, I understand very well how PTs work and what PTs may need in their practice, and so that was what motivated me.
And we could not work without you as sexologists.
How about it? That's for sure.
So do you have any take-home message for the audience to encourage them to see the video that will be available on YouTube?
Yes, definitely. That's good to watch the videos, because that's there. They're kind of rushed and fast, but I think they give a lot of.
I think there's good information. I would also share that, I didn't get to all the training that I think is important, but, for people who would like to have more training in sexual, taking a history or getting information, doing a problem-oriented history, there are 3 important components to education. One is having this knowledge, the knowledge-based training, and that is available at places like International Society for the Study of Women's Sexual Health, as well as International Society for Sexual Medicine and all of their regional affiliate organizations. So that's, you can find that training internationally. That's the knowledge-based information.
Yep.
But then also there's the importance of having interviewing practice, so being able to practice and take a course where you can practice, or have a colleague with whom you can practice asking questions and get over your discomfort. It also, having a supervision is helpful. If people don't have a supervisor who can help, also there are listservs. So the International Society for the Study of Women's Sexual Health, ISWISH.org, has a listserv which is very active, and people can ask questions and get that kind of supervision.
Okay.
As well, having attitude awareness or implicit bias training, and that would be done through it's called a SAR, or a sexual attitudes reassessment program. Many of those are offered through ASECT, the American Association of Sexuality Educators, Counselors, and Therapists. And then ISWISH also is having its first SAR that is designed specifically for the more of a medical audience to do their attitude awareness training, so they can be aware of what they're bringing into the room. And they also have trainings in clinical interviewing skills at their fall course. And then, of course, the didactic training is with all of their educational programs as well as the scientific program. So I just want to name that I will say I'm the treasurer of ISWISH, so I have a bias, but I dedicate a third of my time to the organization because of the trainings.
But I think it's an area of collaboration between the two societies, the ISWISH and the ICS. So
we're beginning to talk about how we can collaborate further, because this is such important information for both sides.
And you, Adi, did you have any take home?
No, he's done.
He's done. Okay. So
thank you.
Thanks for joining us,
Thank you.
and we hope that you will watch the video.
Thank you.
Oh my goodness.